Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features expert insights on complex clinical infections involving Pseudomonas aeruginosa with difficult-to-treat resistance from an educational symposium titled The X Factor, Following the Science to Confront NDR, DTR, and XDR gram-negative infections, featuring Dr. Trevor Van Schooneveld as Program Director and Drs. Emily Heil and Laila Woc-Colburn as expert faculty. Dr. Van Schooneveld is a professor part of the Division of Infectious Diseases at University of Nebraska in Omaha, Nebraska. Dr. Emily Heil is an associate professor at the University of Maryland School of Pharmacy in Baltimore, Maryland. And Dr. Laila Woc-Colburn is an associate professor of the Division of Infectious Diseases at Emory University School of Medicine in Atlanta, Georgia. For the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and start with the patient case.
Patient with rheumatoid arthritis on some mild immunosuppression, has a lumbar stenosis, got a T6 to sacrum fusion in 2021, developed infection actually due to gram-positives, not soon after that surgery, had some debridements, got some long antibiotic courses, but came in recently with new concerns for infection. CT imaging showed subcutaneous fluid collection, tracking down to the screws, and some lucency around the screws, and the SI joint had some fluid. IR drained some of the initial fluid. Patient got started on cefepime. Initial Pseudomonas susceptibilities returned here. I'll point out only resistant to levofloxacin, intermediate to aztreonam, but MICs for most of the other beta-lactams are sitting right around the MIC breakpoint. They're on cefepime for about a week. They go to the OR a couple of times. The screw gets taken out. 1 week later, with the big surgical debridement, they grow a difficult to treat Pseudomonas, and the susceptibilities now look even worse, where it's resistant to virtually all of the traditional beta-lactams. What I always like to tell my fellows is resistance to Pseudomonas is complicated and challenging to predict. There are many mechanisms working together. We can have mutations in target, which give us quinolone resistance, but much more commonly, we have these beta-lactamases, particularly AMP-C beta-lactamases, which hydrolyze some of these beta-lactams better than others, not particularly the carbapenems. But what we get is beta-lactamases combined either with multi-drug efflux pumps, which pump out multiple antibiotics, Imipenem particularly, but not Imipenem, or we get changes in outer membrane proteins, where the porin mutations, where the antibiotics don't get through that outer membrane, which impacts Imipenem susceptibility and Imipenem. So I think these mechanisms working together often are what give us resistance. And this is just a table of the traditional beta-lactam showing that drugs like Ceftaz, cefepime, and Piptazo are, particularly Ceftaz and Piptazo, are hydrolyzed well by the beta-lactamases. Cefepime and Imipenem aren't, but can have increased MICs. But to really give you resistance to those, you need to combine it with other things like porin mutations, which impact carbapenem susceptibility, or efflux pumps, which impact lots of different things. And so what we've traditionally said is that just because you have resistance to one beta-lactam doesn't mean you can't use one of the other ones if it's susceptible. Now, what happens if you have one of these difficult to treat Pseudomonas that are resistant to the traditional beta-lactams? The IDSA guidelines recommend any of the three agents, Ceftolozane tazobactam, Ceftazidime avibactam, or Imipenem relebactam. Now, the reason they recommend this is there's at least some clinical data to support their use. Cefiderocol is an alternative which can be used if you say have carbapenemase production, particularly metallo-beta-lactamase production, but there's much less clinical data. The reason Ceftolozane tazobactam works is there's less affinity of the beta-lactamases for it. It's not affected by the porin changes, and it's not a great substrate for the efflux system. Ceftaz-avi, it's really the avibactam that inhibits the beta-lactamases that restores the activity of ceftazidime. And then the Imipenem is relatively resistant to the beta-lactamases. The relebactam binds the beta-lactamases. And Imipenem is not a great substrate for the efflux pumps, and so makes use of some of the inherent advantages of Imipenem. Cefiderocol is not hydrolyzed by either the serine proteases or the metallo-beta-lactamases, so KPC or NDM, and it has that mechanism where it's actively transported across the gram-negative outer membrane. Now, what's not recommended? nebulized antibiotics, and then using combos like traditional beta-lactams plus tobramycin, aminoglycosides, or polymyxin, when you could use one of those new agents as a single therapy. And so really these three new agents, ceftolozane, tazobactam, Ceftaz, avibactam, and Imipenem, relebactam, are all recommended as first-line agents when you have a difficult-to-treat Pseudomonas. So let's talk just a little bit as we close things out about resistance in Pseudomonas and some of the clinical data. This is a large, numerous center study looking at 3,000 Pseudomonas isolates. They honed down on the resistance. About 15% were Imipenem resistant, about 12% were MDR, and about 8% XDR. These are using CDC and ECDC definitions, where just more agents you're resistant to. What I point out for Imipenem non-susceptible, cefepime being active about half the time. And so we sometimes have these agents still available. But what has excellent activity are the novel agents, Ceftaz-Avi, Ceftolozane, tazobactam, Imirel. But I'd point out they were only about 90% active in Imipenem non-susceptible. It dropped into the 80 to 88% in MDR, and then in the XDR, 70 to 80% active. And so one takeaway from this is when these highly resistant strains are found, it's not a guarantee that one of these novel agents is going to be active, just like in our case. It was baseline resistant to Ceftaz-Avi. The good news is, if it's resistant to one of these novel agents, it's likely you'll still have one of the other agents, because just because you have resistance to one doesn't mean you'll have resistance to the other. And that's what this orange box highlights, that if you're Ceftaz-Avi resistant, about 80% of the time, one of the other agents is going to be available. So it is likely we'll have one of those available. But we can't predict it, and so really do need the susceptibility testing. I tried to put together some of the clinical data. I'll tell you it is limited and it's relatively small and poorly controlled, like in some of these other areas we've talked about. I tried to include only comparative studies. This first study was a retrospective multi-center study looking at ceftolozane, tazobactam for MDR, XDR, Pseudomonas lower respiratory tract infection, and they compared it to best available therapy, which was a variety of different agents. There were some differences in the arms, the ceftolozane, tazobactam, more XDR, more VAP, more combo therapy, but had significantly better outcomes, lower rates of clinical failure in ceftolozane, tazobactam, and in the multivariate regression showed the same thing, and there was no difference in mortality. In a large VA-wide study where they compared ceftolozane, tazobactam use to patients who were treated with aminoglycoside or polymyxin-based regimens for MDR Pseudomonas, again, there were imbalances, younger patients in ceftolozane, more long-term care, more comorbidities, more bone and joint, lower UTI. But again, we see a suggestion of better outcomes, lower inpatient mortality with ceftolozane, tazobactam versus aminoglycoside polymyxin, but other outcomes were no different. And then a meta-analysis, which compared all of the ceftolozane, tazobactam to other regimens, mostly aminoglycoside colistin for gram-negative infections. This looked at all gram-negatives, but in a subgroup analysis of this meta-analysis, there were 6 trials that looked specifically at Pseudomonas. Relatively large number of patients, 300 ceftolozane, 600 comparator, higher clinical cure rates in the ceftolozane, tazobactam arm. And this was mostly MDR, XDR. And again, each one of these studies suggests better clinical outcomes using ceftolozane, tazobactam, although that's mostly compared to aminoglycoside colistin regimens, which we know aren't the most fabulous regimens. What about Ceftazidime, avibactam? Less data here. In a pooled analysis of 5 randomized trials looking at Ceftaz-Avi to comparator, they pulled out 95 MDR Pseudomonas infections out of those trials, mostly UTI and intra-abdominal trials, although one pneumonia trial. Mostly the comparator was carbapenems, although some was carbapenem-based best available therapy, and clinical cure rates were very similar between Ceftaz-Avi and the comparator. Now, in a little different trial looking at Ceftaz-Avi, this didn't compare Ceftaz-Avi to another agent, but looked at the timing. And they looked at the timing of Ceftaz-Avi started early, which is within 48 hours of the culture, versus late. And by late, it was after 48 hours, but late was actually 5 days. It was median of 5 days. And what they found is that patients where it was started early had much better outcomes than those who were started late. And I think this highlights one of the issues we have here is we often don't know that we need some of these novel agents until we get the phenotypic susceptibility data back 48, 72 hours later. And so how do we really move patients to getting on these agents sooner? And it's something I'll talk about towards the end. What about comparison between these agents? There are two studies that compare ceftolozane, tazobactam, and ceftazidime. This was a study done in Saudi Arabia at a variety of centers where they had 200 patients, 100 in each arm. They're relatively sick, about half in the ICU, mostly pneumonia and wound infections. Combo therapy, again, because it's not controlled, ended up being more common in ceftolozane, tazobactam. And the clinical outcomes are relatively similar with similar clinical cure rates and 30-day mortality. Now, just put out at ID Week was the initial results of the Cactus trial, which is trying to address some of these imbalances by doing matching. This is preliminary results, retrospective, multi-center matched cohort study of patients who were started within 48 hours of an index culture on either ceftazidime avibactam or ceftolozane tazobactam. They're being matched on a variety of criteria. And their primary outcome they're looking at is clinical success, which is survival, no need for treatment extension, no infection recurrence. This is a very sick population, about 80% ICU, about 3/4 on the vent, about 1/3 on renal replacement, mostly with pneumonia. And what you'll see here is there's not been really any difference noted in the preliminary data. It did relatively similar outcomes in clinical success, 30-day mortality and recurrence and resistance. And interestingly, in the ceftolozane tazobactam, patients are actually a little more likely to get prolonged infusion, but also a little more likely to get suboptimal dosing of using that 1.5 gram rather than the 3 gram. And so looking relatively similar in clinical outcomes. What about Imipenem relebactam? Less data here. This is a very small multi-center randomized trial where they randomized patients to ImiRel or colistin plus Imipenem when they had Imipenem non-susceptible bacterial infections, which basically means it was ImiRel versus colistin. Most of these were carbapenem-resistant Pseudomonas. In this trial, Imipenem relebactam had better outcomes at 28-day mortality and significantly lower acute kidney injury, not surprising against colistin-based regimens, and better clinical resolution. What about Cefiderocol? The good news is if you're resistant to one of these three agents, ceftolozane, tazobactam, ceftazidime, or ImiRel, Cefiderocol is probably going to be active. This is a large US and European cohort showing that even in these highly resistant strains or resistant novel agents, it's probably still active. Very limited data. The credible CR was this randomized trial of Cefiderocol versus best available therapy that we'd already talked about. In this trial, 12 patients for carbapenem-resistant Pseudomonas, there were 12 in the Cefiderocol arm, 10 in the best available therapy. Outcomes were relatively similar once you took the Acinetobacter co-infected patients out, and clinical cure rates were similar. In the PROVE trial, which is a retrospective study looking at Cefiderocol for gram-negative, the interim analysis, this is again available only by abstract, for mostly carbapenem-resistant Pseudomonas, showed clinical cure rates and mortality rates similar to the other trials. And again, very limited data. And then this last study, which looked at Cefiderocol compassionate use in the US and the EU, while they had 251 patients, they only had 46 with microbiologic and clinical data. As you probably know, there are different breakpoints by the FDA and CLSI. The good news is clinical cure rates looked very similar no matter which MIC breakpoints you used, and we're running in the 60 to 70% range. And so again, suggesting that Cefiderocol outcomes look comparable, but much more limited clinical data. And so I just want to finish with a couple of the challenges we have here in treating difficult to treat Pseudomonas. How do we apply some of our stewardship principles? The problem with Pseudomonas is we don't have genotypic data. And so we can't rapidly identify what's the mechanism of carbapenem resistance. That can be challenging. Our risk factors are poorly predictive of having resistant agents. How do we target these? These newer agents that we want to use, we have to wait for phenotypic susceptibility testing. Sometimes they aren't on the panel. They require additional testing. They may require send-out testing. What agent do we use while we're waiting for that? And then we really do have scant comparative data. compared usually to probably not the most ideal regimens of aminoglycosides or colistins. The agents aren't compared to each other, although we're increasing that data. And then there's often retrospective imbalances in the studies. And so with that, we'll move into the faculty discussion and bring other faculty back. And I think my question to the group would be first, how do you choose between these agents, ceftolozane, tazobactam, ceftazidime, Imirel? Which one do you like to use? How do you choose? Because we have a menu.
I think at least more on the empiric side before you have your testing results back, a lot of that depends on your local susceptibilities. And so I would encourage everyone, if they haven't already, to do that exact question with your microlabs. Take a look at all of your difficult to treat resistant Pseudomonas that are resistant to pip-tazo, cef-p, marrow, and then look at your susceptibilities to ceftolozane, tazo, Cas-Avi, Imirel, and see which one looks the best for you, for your local institution. For us, ceftolozane, tazo is kind of the best bet there if we don't have our susceptibilities back. And so that's the one that we tend to turn to first and reflex our testing to. But that's just based on our local institution susceptibilities.
Yeah, same here as Emily. And I just so you guys remember, we had that shortage of ceftotazo for a while. So we used to use Cefti, Avi, but just go back to your antibiogram and go from there. We use more Ceftolozane and tazobactam than everything else.
Yeah, that's the same for us. We've been in the same boat. So just to summarize, remember, resistance in Pseudomonas is complicated. There are multiple mechanisms, and just because you have resistance to one doesn't mean you'll have resistance to others. And just because you're susceptible to one doesn't mean you'll be susceptible to others. The preferred treatment regimens are ceftolozane, tazobactam, Ceftazidime, or Imirel, and there are a lot of challenges. How do we implement this in a sort of time-efficient manner and with the limitations that we have?
Thank you very much to our faculty, and thank you to our listeners for joining in. To hear more episodes from this session on complex clinical infections involving gram-negative organisms with antimicrobial resistance, click on the link in the show notes. And please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.